I'm giving this short lecture on dialysis, indications of dialysis, basic ordering, and renal emergencies in the ICU. So just a brief outline of what we'll be going through today. I'll be going through the brief indications of renal replacement therapy, modalities of renal replacement therapy present in SGH, a short guide on how to order CRT in emergency, and some useful pearls for renal emergencies in your ICU. So these are the usual traditional indications for RRT, which we have all learned in med school. Hyperkalemia, that's refractory to medical therapy. Severe acute pulmonary edema. Severe acidosis. Severe uremia. Fluid overload that is intractable and refractory to medical diuresis is also an indication for RRT. There is a formula that you can calculate, but generally we can go by clinical settings and we can go by the clinical picture and the urine output for patients. However, there are generally a newer set of softer indications for RRT, usually a combination of factors. The classic picture would be your very sick patient, for example, a PA collapse patient that's on single or high inotropic support. There's worsening acidosis, hyperkalemia. It might not fit your usual classical picture of refractory hyperkalemia or severe acidosis, but together with other factors such as a decreasing urine output, and you know that the trajectory of the disease is not going to go away in the next 1 to 2 days, all this combination of factors will actually lead us to start RRT earlier for patients. And of course, certain drug toxicities, such as calcium channel blocker toxicities. I'll briefly talk about the modalities of RRT that's available in SGH. So I'm sure most will be familiar with what we have available in SGH. We have intermittent hemodialysis on one side and CRT on the other side for most ICU patients who are hemodynamically unstable. And in the middle, we have SLED and SLED-F, or what we call hybrid therapies. And on the left, we have the CRT machine, which generally two types we have in SGH, the PrismaFlex and the Infomed. So generally, if you want to order RRT options in SGH, whatever modality you wish for, HD, SLED, CRT, or even peritoneal dialysis, we have it 24 hours in SGH. Please call renal service. We actually have an in-house renal service. But I will also want to go through a brief ordering of CRT just in case that you need to order CRT at night or after office hours. So as mentioned, CRT ordering is usually done by renal, but if you're in a hurry to start CRT for the patient and our renal team is stuck in a resus and can't come review our patient immediately, so here's what you need to know to how to initiate CRT. I will mainly go through fuss-free CRT ordering, which will be the no anticoagulation mode. And I'll actually highlight certain things that you have to take note of before you order CRT, or when you should be calling us to order a CRT in an emergency instead. Alright, so ordering of CRT is done now via CPOE in Citrix. So if you type CRT, you will get a drop box of 5 CRT orders. You will choose the second CRT order, no anticoagulation, PrismaFlex. The option for Infomed will let the nurses choose the Infomed machines, but generally we have a majority of PrismaFlex machines, so please choose the PrismaFlex option. Once you click the CRT order, you will get this pop-up box. So this is the immediate pop-up screen that you will get once you click that CRT order. As you can see, there are a lot of empty boxes. The ones with stars are compulsory. I will go through briefly which are the ones that require to be filled in. So first of all, please fill in the serology available. The first line would be requesting for HIV, Hep B, and Hep C serology. If in-house serology is available on Citrix, you will find the results available at the blue arrow on the top of the screen. So you just click whether it's done, not done, whether it's reactive, and fill in the dates accordingly. We move down the CRT order screen. The next step would be the anticoagulation. Please choose no anticoagulation for your CRT order. Subsequently, we have the dose of the CRT. It's titled effluent dose. By default, you can start with 35 mL per kg per hour. Once you click the option of 35 mL per kg per hour, the two boxes below, one will auto-populate at 2233. As you can see, this is auto-calculated. You do not need to do anything. But the box below that, which is prescribed effluent dose rate, please manually alter the number to round up to the nearest 500. So for example, here is written as 2233. Please round up to 2500. Or if the weight was slightly different for the patient, like example, it ended up at like 2815 or something, you can round up to the nearest 500 at 2300. This will facilitate your nurses in dialysis. Once that is done, we move to the left of the screen. The other options to fill in will be the functioning vascular access. Please fill in the functioning vascular access accordingly, whether it's a non-tunneled or a tunneled vascular access. Once those are selected, you can choose the options of left, right side, and whether it's a femoral or internal jugular or an external jugular or subclavian vein catheter. Moving down the CRT order form, we have indications for CRT. Please select the indication for CRT. You can select more than one, whether it's deranged electrolytes, oliguria, volume overload, or unstable hemodynamics. Now we are done with the top half. We move to the next section on modality and dosing information. By default, please choose CVVHDF. This is the middle option available on the CRT forms. The next box, QB, please select default 150. The range below that is auto-populated, so you will not need to fill that in. The one that says 120 to 250. The next blank to fill in will be that of initial net UF, which is on the right. You can start off with either 0 or 50, and the range you can change it to 0 to 300. You do not need to worry about the initial net UF you start, as the nurses are well trained. They will usually start off with very minimal or 0 UF at the start when they initiate CRT and monitor the blood pressure and alter the UF rate themselves. Moving down, we have the dialysis solutions. The default solutions are Prismasol. Please do not change the solutions. All right. So if the default solutions are not filled in, please choose Prismasol. You realize that there are 3 blanks here. The left that says Dialysis, the middle that says pre-filter, and the third blank that says post-filter. Do not change the options, and you should get no fluid present for the middle option of pre-filter. Once that is done, you have to manually fill in the dose that is below each fluid box. If you remember, in the earlier step, we had calculated the prescribed effluent dose, which is circled in red on the screen, the number that I asked you to round up to the nearest 500. So you go back to that number, divide by 2, and you split the number into each separate box underneath each Prismasol blank. So for example, for this patient that you had prescribed a dose of 2,500, divide by 2, you'll get 1,250. So you key in 1,250 under both options of Prismasol. We are almost towards the end, so the next section under that will be on additives. You realize there are 2 boxes which are start. Recommended additives, please choose option 1 or option 2 depending on phosphate level, as in the first line. Alright? And on the right, choose both dialysis and replacement bags, which is the third drop-down option. And finally, we are actually done. So you click OK and we'll be done. You can ignore everything else below the recommended additives. The portion on customized post-fluid options, customized additives, monitoring frequencies, additional remarks, all this would be pre-filled in by the computer with the preset default settings. You do not need to alter any of these options. Once you have clicked OK, the orders will be generated in the CPOE, and you can click Submit Orders so that it will appear on the Citrix for the nurses to order and set up the CRT for the patient. So bear in mind that this is meant to be a default, fairly safe, dummy-proof CRT ordering, where it's meant to initiate a CRT order for a patient. It's not meant to replace a direct renal consult. So please still refer renal on the same night or the same day so that we can help adjust and optimize your CRT prescription for you if you're not familiar with it. Alright, so just a few slides on troubleshooting our CRT. Like I mentioned, there are a few caveats to even ordering a foolproof CRT. So the first caveat that you need to know is that when your sodium is less than 130 or more than 150, you will actually need to alter your CRT prescription. But this is a little bit complex, so please call the renal on call should your sodium be more than 150 or less than 130. Please do not order a CRT first. Alright, other than that, once the CRT is ordered and it has started, if you have other problems along the way, such as worsening acidosis or hyperkalemia, you can please call us and we'll help you adjust your dose of CRT. If you are familiar with it, you can adjust it yourself. You can increase the starting dose from 35, which was mentioned previously, to 40 or even 45. The nurses might call you in the middle of the day or night for filter clotting issues. Please call us once again if you have any clotting issues. If you are comfortable with adjusting or troubleshooting yourself, you can choose to restart the circuit or you can choose to alter the flow rates yourself. Just a note of caution, you should remember that CRT is not a panacea. You might have corrected the acidosis, you might have corrected the fluid overload, you might have corrected the hyperkalemia, but please remember that we still have to figure out why the acidosis came in the beginning. Was the worsening acidosis due to poor BP, hypotension? Is there ischemic bowel on board? Is there ketosis? So the job is still not done fully. We have to work out the cause of the low BP, the acidosis, or the ketosis. Another important key point to note, drug dosing for CRT is altered. So please get the on-call MO to check with the pharmacist, especially for antibiotic drug dosing, or you'll run the risk of underdosing your antibiotics for patients. Alright, just a last bit on renal emergencies, some useful pearls. So especially to the ICU setting, so most patients generally will have some form of acute renal injury that usually will end up treating with CRT in the meantime. But some easily reversible causes that can be wrought at the bedside will include pre-renal. So again, this depends a lot on clinical picture of the patient. Clinically, look at the patient. Is there any edema? Does the patient look dry? Is there any JVP? On the X-ray, does your X-ray looks overloaded? If it's pre-renal, the patient generally looks dry, and you'll know that the answer to pre-renal will be to hydrate the patient. With fluid boluses over 1 to 2 hours, you will expect your urine output to pick up very quickly with IV hydration. But please take note, if your urine output does not pick up over the next 1 to 2 hours, remember to watch for fluid overload and have a low threshold for referral for us to consider RRT. Obstruction will usually be relieved at the bladder outlet level if see in situ, but please remember to look out for any post-obstructive diuresis. This is just a common table reflecting the ion concentration of various common fluids that's commonly used in ICU. Probably the only thing that I want to highlight would be that plasma light contains potassium. I know everyone loves plasma light and sterofundin because they are generally bicarbonate containing solutions. But please remember that they do contain potassium too, so avoid them in high potassium patients. A little point on this electrolytemia. Once in a while, you might come into account with moderate to severe hyponatremia if they're not in the gen ward. So the treatment, if they're acutely symptomatic, will be to treat with 3% sodium chloride, 1 to 1.5 ml per kg over 30 minutes. And please recheck the sodium 1 to 2 hours after that. Usually with the general guideline of 1 to 1.5 ml per kg of 3% sodium chloride, you expect your sodium to rise by 1 to 2 points, which would be sufficient to reverse any acute symptoms for the patient. Subsequently, you can regularly monitor your sodium 4-hourly, or you can refer to endocrine or renal to assist you with the sodium levels if you are not familiar. A point on acid-base imbalances. So basic principles again, back to respiratory versus metabolic acidosis, since these are the two most common causes two most common acid-base imbalances that's found in ICU setting. If it's a respiratory acidosis, you have to adjust your ventilator settings. If you have a metabolic acidosis, have to work out whether it's a HECMA or an ECMA and address the causes and treat accordingly. The use of isotonic sodium bicarb judiciously to reverse any acidosis, but please do look out for any hypokalemia, calcium, or low magnesium levels with the use of isotonic bicarb. And finally, MINAs are present in Singapore, but once in a while you do get the rare sparrow. If you do get patients who are fairly sick and you see an unexplained bicytopenia with anemia and low platelets, and maybe you have an AKI and some CNS symptoms, just remember that at the back of your mind that there's this emergency called TMA or thrombotic microangiopathy syndromes. So send off the PVF, Hepto, LDH, PT, and PTT, and refer hematology if suggestive. So I actually come to the end of my presentation, but I think just a quick summary, the whole purpose of this lecture is not meant to replace a renal referral. All right, it is once again meant to remind everyone on what are the traditional indications of RRT and to give you an easy way to start and order CRT at an urgent, to order CRT if you are having, to order CRT if you have a very sick patient in front of you and we are not able to come and assess the patient and help you immediately. All right, but at the end of the day, you still have to refer renal, all right, so that we can follow up with the patient and help you adjust your RRT modalities. Right, thank you.